Thank you very much. Good afternoon, everyone, and thanks for the opportunity for presenting our collaborative work from various universities and CAPRISA in South Africa. There's two of our authors who have declaring interests. All other authors have no competing interests. So there's reassuring evidence that in utero exposure to tenofovir TDF does not affect pregnancy and newborn outcomes. In adult studies, however, TDF was associated with lower bone mineral density. Growth trajectories in HIV-exposed and uninfected infants have been well described. The association between in-utero exposure to TDF-containing antiretroviral treatment and infant growth has yielded inconsistent findings. Growth outcomes in HIV-unexposed infants and those exposed to in-utero TDF-based PrEP are limited. So our aim was really to determine if there was an association between infant growth metrics and in-utero exposure to TDF in unexposed infants. We also measured tenofovir concentrations in red blood cells using dry blood spots collected during pregnancy. So we had infants born to women. This is part of the CAP016, which is a randomized control trial, and this is a segment of that trial. Were randomized to TDF PrEP or no PrEP, so immediate or deferred PrEP. Gestational age was determined in all participants using ultrasound scanning at an enrollment visit before 28 weeks. We followed up the infants and the moms, the infants at 6, 26, 50, and 74 weeks of age. We had a trained research assistant who measured the infant's weight, length, and head circumference using a calibrated infant weighing scale, a stadiometer, and a non-stretchable measuring tape. The WHO World Organization growth standards were used to calculate both age and sex-appropriate Z scores for weight, length, and head circumference. As part of a post-hoc investigation, we looked at tenofovir stored dried blood spots from the moms at 2 visits, 4 and 12 weeks post-randomization, and extractions of 50 micromole DBS were tested for tenofovir. Liquid chromatography tandem mass spectrometer was used, and we used the lower limit of 16.6 femtomoles, and we used Stanix and Chabanda et al. We extrapolated their adherence metrics, where 1 dose per week was about 93, and 500 femtomoles was 5 doses per week, representing 70% adherence. We had 3 groups based on these data, and one was the TDF unexposed infants, then infants exposed to maternal tenofovir levels below 500, and those above 500. We then compared weight for age, length for age, weight for length, and head circumference for age scores at the 6, 26, 50, and 74 weeks. Linear regression model was used to compare the growth trajectories between the groups over the time. We adjusted for maternal, socioeconomic status, age, low birth weight, and infant sex. We use a correlation coefficient to report on these scores. This is a metric just to show the follow-up. As you can see, the follow-up, we did struggle. It was in the COVID-19 period, but there's also a lot of internal migration following delivery in many of our studies looking at follow-up of moms who deliver in the 2 urban centers. Now, of the 228 tenofovir exposed infants, 43.4% were undetectable to the mums had undetectable to 200, so about 15%, less than 15% adherence. For 26.8% had 2 to 4, we correlated 2 to 4 doses, and there were 68 infants whose mums had more than 500 femtomoles, which is 5 or more doses. So when we looked at the growth metrics, we had these 3 groups. Those are 68 infants with greater than 5, whose mums had greater than 500, 160 infants less than 500, and the 226 with the deferred PrEP arm. The median age of the moms was 23, 60.18% lived in low-income households where the reported monthly income was less than $65 a month. The baseline socio-demographic characteristics were comparable in all groups. 91.4% of the infants were born at term, and 92% of normal birth weight, more than 2.5 kilograms. Birth anthropometric measures were comparable between the groups, except for the lowest mean head circumference for age score reported for infants born to women with a TFF tenofovir above 500. Now, age-stratified mean weight for age, length for age, weight for length, and head circumference for age were comparable. The mean length for age scores were consistently low across all groups from 6 weeks. The linear regression model for in-utero exposure to tenofovir levels was not associated, however, with weight for all the growth metrics observed over time. And this was, I'm just showing you some of the graphs. As you can see, generally, the weight for age, there is overlap in the two groups, the PrEP unexposed and those less than 5, the TNF levels were less than 500 and slightly lower. The weight for length, as you can see also, the group was slightly below the two groups of PrEP unexposed and TNF levels of less than 500. But as mentioned, they did not come to significance on the length for age for all three groups were lower. And as you can see, the PrEP unexposed later in the cohort, later in the weeks, you can see that actually fell. And the breastfeeding metrics seems to correlate with that, and that's how we explain that component. The head circumference for age as well were more or less similar with the group with greater than 500, slightly below the other two groups. So the post hoc analysis of a randomized non-inferiority PrEP in pregnancy clinical trial is what we're showing. The in-utero exposure to high concentrations of tenofovir as opposed to lower concentrations or no exposure was not associated with adverse growth trajectories in HIV unexposed breastfed infants in the first 18 months of life. The growth metrics were lowest among infants exposed to high concentrations of tenofovir, but not significantly lower than other study groups. So suboptimal adherence to daily oral PrEP has been documented, and in our study we really confirmed the suboptimal adherence using a reasonably objective assessment. There was, however, lack of an association between infant growth measures and in-utero TDF-based PrEP exposure consistent with TDF-based PrEP safety studies. The weight for age scores were lowest for infants exposed to higher tenofovir concentrations, and unlike other growth metrics, that should be the length for age scores remained lower throughout the study period up to 18 months. Further follow-up growth parameters in infants beyond 18 months would be essential. So our conclusions are really that there is we're providing additional evidence of a lack of association between infant growth restriction and in-utero tenofovir exposure using an objective assessment of PrEP exposure. The small sample size, especially of the group later on, makes interpretation difficult, limiting its generalizability. However, it provides important reassuring safety data on growth outcomes of infants exposed to maternal TDF-based PrEP regimens in pregnancy. Those are the references, and we'd like to thank all our participants in the study and all the collaborators. Thank you.